Let's talk about vedolizumab. We've made some progress. The therapy was approved for both Crohn's disease and ulcerative colitis in May of 2014, and we now have additional information about how these therapies are working for our patients. I do have some disclosures that are relevant, although all these slides and my opinions are my own. So when I conclude in the next 20 minutes, I'm going to update you on the mechanism of vedolizumab, on some thoughts about how these therapies have been demonstrated to work in our patients with Crohn's and UC, and then provide you with some practical tips about where to position the therapy and how to think about it in the future. Let me remind you that in the United States, we are unique in that we have 4 anti-TNF therapies available for IBD, 3 for Crohn's and 3 for UC. And we have a second class of biologics, so just to get your mind in the right gear here, we have anti-TNF as one class, and now we have the adhesion molecule inhibitors, or anti-integrins, as a second class of biological therapies. In GI, we were sort of one-track minds for a while, where we thought biologics equals anti-TNF, and you just have to keep in mind there are going to be more classes of therapies arriving very soon. The 2 anti-integrin therapies that are currently available and approved in the United States for the treatment of inflammatory bowel disease include Natalizumab, which is approved only for the treatment of Crohn's disease, also has approval for the treatment of multiple sclerosis, and Vedolizumab, which is the focus of this presentation, which treats both Crohn's and UC. And we'll talk a bit more about what that mechanism is. So both Natalizumab and Vedolizumab target adhesion molecules, which are the molecules which enable lymphocytes to find their way to their target organ. Our body has a variety of different types of adhesion molecules, or otherwise called integrins, that essentially, some people call them zip codes, that tell the body where the immune system needs to be activated and what its target organ may be. The zip code, or the targets for Natalizumab and Vedolizumab, are actually slightly different. But the way they work is by inhibiting the integrins, you actually prevent the cells from leaving the endothelium and entering the epithelium. So you're basically shutting off the off-ramp from the blood vessels into the gut mucosa. And by turning off the cellular mechanism, at least this is how we believe it occurs, you are shutting down the cellular component of the inflammatory cascade in IBD. That is also why we believe it may be a little slower in its onset, although that's unproven. But nonetheless, it's an interesting concept. And it's also why we believe it may be a more stable mechanism, because by controlling the cellular mechanism of inflammation, it appears to have a little bit more forgiveness for changes in drug levels or disease activity compared to cytokine inhibition. When we look at the 2 different drugs that I've mentioned, Natalizumab and Vedolizumab, you can see the distinction here. Natalizumab targets alpha-4 and therefore is less selective by targeting both alpha-4 beta-1 and alpha-4 beta-7. Alpha-4 beta-1 is expressed on lymphocytes that are on their way to the central nervous system, and alpha-4 beta-7 is unique to the gut mucosa, or at least the mucosal immune system that's targeting MADCAM, which is the mucosal-associated immune system. So the gut epithelium, and you can appreciate, involves our entire intestinal tract, and that's also the liver, the pancreas, and even the back of the pharynx. So that might provide you with some insight as to where this therapy is actually working and why we may observe certain effects of it. Natalizumab is the target of VCAM and therefore is less selective and can affect the surveillance of the immune system in the central nervous system, which is why it's a very effective treatment for multiple sclerosis. It's also why Natalizumab was associated with reactivation of a brain infection called progressive multifocal leukoencephalopathy. You understand now in the distinction between these therapies why it was not expected, nor has it been seen, that Vedolizumab has associated with it any brain infections. Now, Natalizumab was actually a very effective treatment and remains a very effective option for Crohn's disease. It was not studied in ulcerative colitis because of the emergence of the brain infection, and therefore the pharmaceutical company didn't pursue it. But I'll remind you that in the ENACT-1 and ENACT-2 trials, the patients who responded to this with moderate to severe Crohn's actually did quite well, and of those who responded, there was quite a stable response over time. Now, it did miss its induction endpoint in one trial, and therefore there was a third trial called ENCORE that was performed that did have significance and led to the drug's approval. In the University of Chicago, we were avid users of Natalizumab, and in fact, one of our colleagues and a faculty member at this meeting today, Atsushi Sakuraba, led our investigation of over 100 of our patients who had been exposed to Natalizumab, and the real-world experience with Natalizumab looked just like those clinical trials, in that once you identified who responded to the therapy, they did quite well, and it was a very stable response over time. So let's now focus on the distinction, which is the Vedolizumab target, and we'll focus on that for the remainder. The first thing that I think is really interesting, I love this study. This was a primate model in which they studied the gut selectivity of Vedolizumab. And what they did was they administered to these primates, non-human primates, both oral cholera vaccine and the hepatitis B vaccination, which you know is parenteral injection. And what they demonstrated in this very nice, elegant study was that when you're on Vedolizumab, or when these animals were on Vedolizumab, they were unable to convert to active immunity when they received an oral vaccine. Yet they were very able to still convert to active immunity when you bypass the gut as the delivery system. So the conclusion here was that Vedolizumab was effectively shutting off the lymphocyte exposure to oral therapy in the gut. So one of the messages here is not only the selectivity of this particular inhibitor of the immune system, but also that we might be able to safely administer parenteral vaccinations without worrying about conversion, which we've seen with some of our systemic immunosuppressive therapies. So I encourage you to take a closer look at this study if you have more interest in that. Now, there have been a number of phase 3 and post-marketing studies that led to the current database of Vedolizumab information, and I'm going to summarize them very briefly, but there was the GEMINI 1 study in ulcerative colitis, GEMINI 2 in Crohn's, there was the long-term safety follow-up in both UC and Crohn's. GEMINI 3 was a second study in Crohn's, which just looked at induction and had a higher percentage of TNF failure patients, and then a variety of post-approval studies that I'll summarize for you in a nice table today. So just to summarize all the GEMINI programs, the official GEMINI 1, 2, and 3 programs in a single table, bear with me on this. We'll start with the first row, which is the ulcerative colitis population. You can see that it had 40% prior TNF failure, primary endpoint of response at week 6, remission at week 52, and the secondary endpoints of week 6 and mucosal healing at week 6. Vedolizumab-exposed patients were statistically superior to placebo in all of those endpoints. Looking at GEMINI 2 and 3 for Crohn's disease, remember the distinction between those two in that the GEMINI 3 study had a much higher group of anti-TNF refractory resistant patients and exposed patients. In addition, I want to point out to you that the GEMINI 3 study did not reach statistical significance over placebo for its primary endpoint of remission at week 6, but a secondary endpoint of remission at week 10 did achieve statistical significance, which I think is an important message related to the timing of the therapy. At least that's one explanation for it. You'll also notice, though, that steroid-free remission and remission at week 52 were significant in the Crohn's populations. So important to understand that perhaps there's a distinction in when the therapy may work, and looking too early can actually result in a false negative result or a negative result that you can't interpret clinically. The other message about this is similar to what we saw with Natalizumab, both in the real world and in the pivotal trials, is that patients who respond to the therapy continue to respond over time. Now, I'll remind you that the blue curve here, which represents placebo, were patients who received Vedo and induction and then were randomized to placebo in maintenance phase. That's why you see that they respond there on the left, and you see the separation of the curves over time. But whether patients received every 8-week infusions or every 4-week infusions, they continued to do quite well with the therapy and were stable, with very low loss of response. A reminder that the FDA approved it for every 8-week infusion as a maintenance. Same thing seen in Crohn's, although the separation occurs a little bit later from placebo, nonetheless important. And I'll just point out what Gil already taught us, which is that using the CDAI as our measure of efficacy has its limitations, and that may be why the placebo response stays higher longer in a Crohn's population. Now, there was a recent publication that you may not have seen, but I'll point you to by Jean-Fred Colombel and other investigators that was in Gut this year, looking at the long-term safety. Remember, that was part of the original program for the development of Vedolizumab. And the integrated safety data with long-term follow-up up to 5 years in a large number of patients, 4,800 patient years, There were no cases of PML, 0. So even though the FDA had said that in theory it could be possible, it remains unreported, and therefore we continue to believe this is not going to happen based on the mechanism of this therapy. There were a couple independent risk factors for serious infections on Vedo, but they are not new, and they would be a better explanation than the drug itself. In other words, for ulcerative colitis, these were sick patients or patients who are on narcotics, which we know are always bad actors. And in the Crohn's population, as well as in the combined population, younger age being on concomitant steroids or narcotics were all risk factors for infections. Infusion-related reactions were actually quite infrequent, I think probably lower than what we've seen with infusion anti-TNF infliximab, and the malignancy rate was not elevated at all. There were no new safety signals in this study. So I think this is reassuring. I've been telling my patients on therapy that the long-term follow-up looks like the safety that was seen in the pivotal trials, and that they should be reassured that this remains a safe therapy compared to other options. Now, looking at another question, which is, do patients who are TNF naive do better if they receive Vedo early? And we have just post-hoc analyses of patients who are either anti-TNF naive on the left or those who are prior anti-TNF failures on the right in both ulcerative colitis, which you can see here, and then the next slide, Crohn's disease, patients who are TNF naive, next slide, thanks, do slightly better, although it's not overall dramatic, and remember this is post-hoc. But the general message we always accept is that the patient who's failed many therapies, when they get to the next one, they may not do as well as the patient who gets a treatment naive. And that's true for TNF too, by the way. The TNF alpha naive patient is more likely to respond to your first TNF than to the second TNF, et cetera. So just keep that in mind. Next slide, guys. Thank you. People ask about fistulas and Crohn's disease. There is a post-hoc evaluation of the patients who had fistulas in the GEMINI series with vedolizumab, and you can see that the week 14 closure rate was 28% compared to placebo, and the week 52 ongoing fistula closure rate was better than placebo as well, which is not surprising. Some people forget that in Accent 2, which was the infliximab fistula study, which led to label of infliximab for fistula disease in Crohn's, the rates were actually similar, although that study was powered and designed to specifically ask that question as opposed to the pooled analysis and post-hoc evaluation in the vedolizumab experience. What about using Vedo with combo therapy? Some say, okay, well, if I use it with a combination immunomodulator, I'm going to lose my safety benefit, and I think that's a valid consideration. First, I'll tell you that, at least based on the GEMINI series, we do not see an overall efficacy benefit by using combination therapy. But reminder that this is not designed like we heard earlier today in naive patients where they're getting both drugs up front compared to a single drug. This is just looking at who's in the trials and whether they were in combo or not. And remember that if they got into the trials, they probably had already failed an immunomodulator and other therapies. So this is not necessarily the best way to look at this. I will tell you that in our experience at U of C, where we've treated over 300 patients now, about half of them or more are on combo therapy for a variety of reasons. What you really want to know, though, is there a safety difference? And at least based on the GEMINI series, when you look at infections and severe adverse events, there is not a difference whether the patient's on a combination immunomodulator with vedolizumab or vedolizumab alone. Steroids may increase that risk, but it wasn't seen when they reviewed all this in the vedolizumab and GEMINI series. So at least for now, if you think a patient needs combo therapy for a variety of reasons that we can discuss in the panel discussion, you should do it, and you should keep in mind the usual risks for those other therapies. Comes up also whether we can use this drug in pregnancy. So it's FDA category B, and we do have a large series of patients who receive natalizumab treating multiple sclerosis who've been pregnant, and there haven't been any concerns with that. In the vedolizumab population, there were 24 vedolizumab patients that were reported by Marla and Uma Mahadevan looking at exposure during the clinical trials. And now a slightly larger series was presented at ACG this past year of 27 women who were pregnant on vedolizumab and 19 males who were on vedolizumab whose partner was pregnant. And there has not been any adverse events seen. This is probably similar to our other monoclonal antibodies and what we understand about transmission during the third trimester or late second trimester. So in general, we think this is safe, and I've been continuing it in my pregnant patients. Now, if you have your device, you can study this a little more carefully, but I'll point out to you that there have been a large number of post-marketing experiences reported throughout the world. The largest is the Boston experience that's actually fully published. The U of C experience is being peer-reviewed, and the French multi-center experience. And I'll just show you that actually two things are notable. One is that the safety of the therapy seems to hold up in the real world. The second is that the overall efficacy of therapy is the same or even a little better than what was reported in the clinical trials, especially in Crohn's disease. And then the only pediatric experience that I'm aware of in the post-marketing has been from the Cedars-Sinai group that you see in the bottom row here. There are now some week 52 outcomes that are trickling out, including our paper, which I'm hopeful will get published soon. So here are my practical comments about using vedolizumab. The first one, as many in the room already know, is that insurance companies don't distinguish Vedo from anti-TNF, and they still want you to check TB and Hep B before you start therapy. There is no safety risk of reactivation of latent TB or worsening of hepatitis B with vedolizumab. However, the insurance companies don't distinguish. They don't have the bandwidth to actually understand things at the level they probably need to. And I am fighting against this with the CCFA, but I'll tell you in the meantime, you should probably just be checking it, get it sent off early, make sure you document it, and just avoid your headache until we get this clarified some more. Another issue that's come up is that there are some patients who develop joint pain after starting therapy, and it's not entirely clear if this is a real side effect of the medication, whether we're uncovering some parallel coexistent extraintestinal manifestation that was otherwise covered when they were on systemic therapy, or if it's maybe just withdrawal from the steroids you had them on. So we don't fully understand what's happening in this case. I will tell you that it has not limited my ability to use vedolizumab in the vast majority of my patients. There's one patient where I had to stop the therapy because of her joint problems. Usually we can treat with a short course of steroids and continue on. Occasionally I've added methotrexate. We've not had much difficulty getting dose escalation. We've gone to Q4 weeks in patients who are not responding as much as we'd like, and then I usually do that for 3 or 4 months and reassess. And if there's not a clear response, we move on to a different mechanism. And I would lastly say that we're hopeful that we'll have a commercially available drug assay soon. And at DDW this year, there were a couple abstracts looking at vedolizumab levels associated with response from the clinical trials and some other work that people are doing now. And similar to other therapies in our field, no surprise, the higher the drug level, the more likely the patient is to have had a clinical response. You'll notice, however, that it seems to plateau. It's not that the higher the level, the better they do. You sort of get to a point where you have the most, at least what we've been measuring with the doses available, and you get to where you need to be. So certainly something to be said for the same message we've talked about before, disease intensity and drug levels or drug exposure. And in fact, similar to what we've seen with anti-TNF, are the predictors of patients not responding to therapy. You know this already, or you should. Low albumin, the sicker patient, the patient with the high CRP, these are the ones that you know don't respond to TNF or basically any of our treatments. They're also less likely to respond to your Vedo. So if you have that sick patient in the hospital with severe UC who's got an albumin of 2.4, vedolizumab isn't going to be your drug. We don't have inpatient hospital data really to say that, and I don't believe this drug is going to get to where it needs to be to treat that patient. That's the wrong patient. In fact, we've been exploring, and others have started looking at whether using cyclosporin to salvage that patient and then using vedolizumab as your maintenance later is an interesting concept. But remember that the same principles of pharmacokinetics apply with your monoclonal antibodies. And so I'll end with when we might consider anti-integrin therapies before anti-TNF, because I still think that this is not clear to many of us. The first, of course, in patients unresponsive to conventional therapies and anti-TNF. Well, that would mean that you have to think about whether you would be using an anti-TNF in a specific patient or not. In patients intolerant to anti-TNF therapies, so if a patient's been on one before and they've had some class effect that is an absolute contraindication to going back to it, like myelitis or neuritis, or intolerable side effects that makes the patient very anxious, and probably you too. In patients with unusual or other immune conditions, so that systemic immune suppression may not be such a good idea. So we've thought that maybe we should use vedolizumab in people who have had organ transplants with active IBD, where they're already on immune suppression. And the mechanism of why they have active IBD despite immune suppression for their organs is very interesting. And those who have hereditary or acquired immune deficiencies, although I'll tell you anecdotally, we've treated a couple of patients with a CVID enteropathy with vedolizumab, and it's hit or miss, so we're not quite sure about that yet. And then there are emerging considerations, like your older patient, the one who has a higher risk of opportunistic infections, positioned before other systemic therapies as just an algorithm we might use, maybe in UC and not in Crohn's. And then I mentioned to you using it in combination with tacrolimus or cyclosporin. And don't forget, even if you're nervous about it, natalizumab is still a good drug. And patients who lose response to Vedo might still benefit from another drug within the same class, natalizumab. And if you're nervous about that or you don't have experience with it, refer to one of your expert colleagues who can help you. So I hope I've updated you on what we know about this particular mechanism. There are a couple other therapies that are in clinical trials that are similar, but we've certainly come a bit further in our understanding of how to use this drug in our practice, and I'll look forward to your questions during our panel discussion. Thank you very much.